Well, it's an absolute pleasure to welcome you all to our dynamic panel discussing challenging day methods through virtual care. I'm heading for that. It's a real honour to be collaborating with our panel members, which I'll introduce to you shortly. For those of you who attended the DC symposium with you who know and would have heard my presentation with my friend and colleague, Dr. Rhonda Kerr, know of my passion around virtual care and digital health and its potential for fundamentally transforming patient care. Through my work at many projects, I had the real privilege of collaborating internationally with some leaders around designing hybrid models of care and then curating the actual digital ecosystem that enabled them. So today's panel discussion resonates really deeply with me as we explore how to change and evolve the digital care model using virtual solutions. So before I proceed, our discussion, I'll introduce our panel members. So firstly, let me introduce my friend and colleague Miranda Shaw, General Manager of RPA Virtual Hospital. Miranda, if you want to weigh in. Miranda has over a decade of experience managing community-based health services from prenatal to end-of-life care. She has led Australia's first virtual hospital, and under her leadership, RPA Virtual Hospital has been at the forefront of virtual care and was recognised with a New South Wales Premier Award for Excellence in Digital Innovation in its first year. Miranda is also last week. Yeah, that was the strawberry. Congratulations. And she's also, amongst all this, the adjunct senior lecturer at Centre for Primary Healthcare and Equality and UNSW. Next, it's a pleasure to introduce Dr. Susie Miller, Director of Strategy, Quality and Technology at the Victoria Virtual Emergency Department. Through our discussions, I think Susie and I have decided that we are digital kindred spirits and that with her wealth of experience, with decades across Australia and the US in medtech ecosystem, she has served as a Chief Medical Officer, investor and board member. Since joining the VVND in 2021, she's helped expand his reach from 15 to nearly 1,000 patients daily, establishing it as a cornerstone of acute care in Victoria. Her focus is on leveraging technology and alternative care pathways to create equitable, high quality and accessible health system. Thank you for joining us, Susie. I'm also delighted to introduce Samantha Pine, Director of Clinical Excellence Queensland Healthcare Improvement Unit. In her role, Samantha drives ecosystem collaboration, evidence-based innovation, and service transformation. With her background in clinical, academic, and policy work, she's recognised for her strategic expertise in triple helix partnerships, designing smart hospitals, and advancing connected health system in Australia and in the UK. Please join me in welcoming our esteemed panel members.
Thanks, Bob.
So to set the scene for you today, each of my panel members are going to provide a very short overview of the work that they're leading currently. So Miranda, I'm going to start with you first. Thanks very much, Hedia. So we will be very grateful. We've been told that we're between your cocktails. Yeah. The time we're by a little over, so keep it very short. Arcare Virgin Hospital is part of City Level Health District. We're located just up the road. We have it opposite RPA Hospital. We're a district-wide status, and we established ourselves as a small virtual hospital in February 2020. So we certainly weren't the first virtual service in Australia, but we believe we were the first to design ourselves as a hospital facility. We moved very quickly onto COVID, and we had the first COVID in the community program from March 2020 using virtual care. We're designed to deliver hybrid care, which distinguishes us from some of our virtual care services. So our primary objectives actually are some synergy here between the former speakers creating platforms. We're all trying to support patient flow in acute facilities, deliver safe, high quality, efficient services, and of course enhance the patient experience of care. Continuous evaluation is absolutely critical to what we're doing. We're sort of, really trying to revolutionise healthcare delivery. And a research agenda, really important to contribute evidence to emerge appearance, he says. Perfect, thank you, Miranda. Is the Susie, I'll come over to you. Okay. Being accredited is really important. So we're often having to convince as stakeholders of the safety and quality of the care we're delivering. So being accredited as a standalone virtual hospital facility is really essential. We're accredited under the national health safety standards, the RSCGP, and the Australian College of Medicine. This is where our head office and our virtual care centre are located. So it's a really beautiful 1941 Holman Prize winning building, the Key Choice of this building, the Handel. So just very quickly, what kind of care we deliver? This is one of our virtual care clinical nurse consultants. We do have a virtual urgent care, a fracture clinic, and a low back pain service, a rehabilitation service, mostly for patients post-stroke, post-tube, and knee replacement, a trauma clinic, and acute respiratory clinic, wound care demand centre that uses AI in an app called Tissue Analytics, a couple of chronic conditions, and a virtual nurse assist program that's actually for early career nurses in the highways and communities at worst, and a range of other complementary services that are listed there. As I said, we're a hybrid service, so one is virtual, the other is in person, and in person we have about 90% of the care delivered in patients' homes by our nurses and our health staff, and a small number of about 5 ambulatory care clinics located across the boundaries of our local health districts. So we deliver hospital in the home by therapy, we care, respiratory, chronic care nursing. Palliative care is the year to go have about 500 palliative patients within the area to retiring. Continence management, it was exciting but important. And just the final slide here, this is a map of New South Wales. The horizontal arrow is what we're doing currently. So we're based in Sydney, delivered services for Sydney local health district, but also the far west of New South Wales. In the brackets there is what we're moving to from early next year. We're about to launch a statewide virtual urgent care service funded by New South Wales Health. So we'll be covering all of Metro Sydney, Uluru, Padron, and the Central Castle. Thank you. Thank you, Miranda. Hello, Edwise.
It's okay. I'll stop. So I'm at emergency physician rather than American, so I will talk very quickly.
That's the
worth it. So the Victoria Virtual ED started 4 years ago, October 2020. There was a brilliant emergency physician named Warren Scher. We was a warrant. She was really bored. She said, "This is ridiculous. I'm going to change healthcare." And we did some Googling and found a digital health expert at Butcher University in Melbourne, and voila, we were born. And actually, it was a virtual triage, one hospital on the right house. So the one hospital solution was one doctor, one nurse, one clerk, 8 to 15 patients a day. I joined a year later in September 2021, hot in the code, and we very, very quickly grew to become a housing provider to the metro area in the state. And Victoria joined us. They said, "You know what, we have private patients in the home that don't need to go in the hospital. So why didn't the paramedics call the emergency doctor and we take care of it at home?" And that's what it worked. So we went from metro area to the state. Fast forward, we've seen 400,000 patients, 200,000 delivered last fiscal year, and a growth mode. So, out of work and Sunday, there's like 220 patients. We're seeing about 6 to 700 overall. We'll always get 1,000 over Christmas. We are statewide as sponsored by the Victorian Department of Health, and I know that we're very taking the risk on this. And we serve many, many partners now. So you could be in an urgent care center out in the rural area. There's no doctor on duty. You can call us. And that's Victoria can call us anytime they send a patient can safely to stay at home. And of course, we see lots of aged care patients who really should be cared for in their place. The residents can that's what they want. That's the core of what we do. So the line is up to the left. That's the point of that slide. Let's see if I can go to the next slide. we're doing horrible. We keep about 80% of our patients out of the hospital. We close the care of 50% of those, and of the 30% of everything, they're sent to perhaps their GP or to an urgent care center led by a GP or maybe a residential emergency service or an RCF. And the patients lost 90% positivity rate, of course, because you have to stay in your home. You didn't have to drag the kid in the hospital 2 in the morning with all those kids in the car, if anybody had children. The town there with fruit at 3 a.m. is all of our neighbors. So each rose is successful, and we call ourselves the Victorian Virtual AD. The very soon, this will be the Victorian Health Service, because we're currently doing observation wards, specialty clinics, and this is growing very rapidly. And the point I'll leave you with is, care comes feel scary at first, and it's where it probably should be. So we need to completely flip our thinking, and it's not what care can be done at home, it's why is the care not at home, and that's what we're learning.
I appreciate that we have a lot of a couple of international delegates in the room. So just to contextualize Queensland, where I'm in, born, second largest jurisdiction in Australia, covering almost a quarter of the population, quarter of the country. I like to say, we've got almost 2,000 islands in Queensland, and within Queensland Health supporting 230 plus facilities, plus labourers in facilities pipeline of activity. At the moment, we have over 300 days of sunshine each year, which is wonderful, the Sunshine State. So that's a bit of sectorisation where I support healthcare. Within the healthcare improvement unit, this is really here to kind of ground the thinking in what is important to us within the Department of Health and how we straddle all hospitals and health services and sit somewhere between the politicians and the people with the boots on the ground, and we try and support the implementation strategy, but then the development of strategy that really is user focused as well. Within this, well, some of all of the areas of focus that we're looking at, and that's all the different stages as consumers move through the health system. But that big orange arrow there is that state and shift narrative. If anyone is aware of the work of Martin Curry in Ireland, the Centre Shift Tonight's initiative is really, really fundamentally important. It's a little bit contagious within Queensland Health because we have funded it. There's an inverse incentive because we are funded to create facilities to keep people coming into our facilities. And primary care is the responsibility of the Commonwealth, not the state. Although we know we need to deliver care and home, our funding wants to start there, but that doesn't mean we need to stop pushing those boundaries and supporting in any way, shape or form that digital transformation, digitally enabled care closer to home. The aims is really important, and that's branding our setting what we are doing in the healthcare improvement unit. Meaning you'll probably be aware of the quintuple aims of healthcare improvement. We're under an additional aim of looking at environmental sustainability, which is really key to us, given that we're not legislated like the NHS is. So overarching concepts of relevance to us within this Department of Health at Queensland is very much a smart hospital. They're very touched on it to what they're going to talk about it shortly. They're very much how they can embed technology, really to understand the microprocesses within facilities and understand that alignment between form and function too. We can't do things in isolation, so working with the whole ecosystem and stakeholders to coalesce around common goals is really key. And designing environments that really support evidence-based improvements is really, really important. The pictures on the right-hand side there are, it's the operating theatre of thought and 9 ward. They're not live clinical settings, they're simulated settings. Most healthcare facilities have them, and also academic institutions too. And the paper at the bottom there, which you're not intended to read live, is just more looking at what is a smart hospital. And we don't, that's not a standardized terminology. This is a paper I wrote, it was published last year with a colleague of mine from the UK, Professor Shino's son. It's starting to articulate what is a smart hospital, how we really need to move in that direction, but it isn't a state to achieve. It is a concept that we can continuously evolve through or enable through the evolution of technology. Here, within three technology changes in Queensland Health, this is the fun, obviously the rollout of electronic medical records. We can't digitise our whole healthcare system unless we get those kind of foundations right. At the moment, we're a little bit behind in that all of our 230 facilities are digitally, our paper-based, so you made it even open a new facility that is a paper for itself, which is not what we want to do. We want to open facilities that are electronic, but that's not the reality. Real-time application systems are a huge enabler of providing clarity, opacity, improved processes and flow. But we don't, it's not strategically deployed yet across the state, and that's within my portfolio to start to uplift that in all of our facilities. And that middle picture there is what station from which is probably very familiar to many people here. Our workforce is very, we move around. But we've now just got to start pushing the desks and the computers within between patients. So it was really key to us is to look at listening and AI transcriptional services. Extended reality, these things kind of straddle, the value of within the hospital and in the community care too. So looking at EDSA and the use of holograms, that's my son likes turns a hologram for the very first time a couple of weeks ago. I've shown them versions of how to like an Opa. But really thinking like there are lots of opportunity through these technologies and how we apply them in different facilities, the environments that we need to project these images from hospitals and into the community in different ways. Robotic the process automation is obviously very key, and the use of drones. That picture down the bottom there is drones delivering care closer to home too, and how we can leverage that is incredibly vast. At the moment, a lot of these things are not very evidence-based, and so a key driver of this is to create those environments that support that generation of evidence so that we can strategically move in the right direction. I can't touch on all of these things without acknowledging the digital front door and huge fragmentation that does exist across the system, and how we help clinicians navigate the right care at the right time in the right way. And digital health literacy is obviously a huge enabler of change, but we don't, as the system, strategically invest in a workforce to support that, to meet consumers where they are in the digital health journey and help them overcome barriers, including access to care, but also how they can use technology safely so that they can avail themselves of these great technologies going forward. So we can move through remote patient monitoring, of course, something that we've worked on today, and new models of care that are enabled through technology. I will go into this a little bit more so that, and colleagues before spoke about RPM and the value that it has, but at the moment, this is just the depiction of the barrier that's down spread across all of our facilities and the communities, that there's a multiplicity of technologies that are being developed, thousands of them, different sensors that are actually very thorough and they can transform care, but they don't come with their own dashboards. That's a huge burden for our staff to have to learn the human-computer interaction, but then the data is very silent through these different systems and they're not aggregated. So moving towards a system that allows us to orchestrate these technologies into a central platform, for health and health information exchange, will then open the door for us to support scan and spread right across the system. We don't want our workforce to be able to have to log on and off to 10,000 different dashboards. We're never going to get into a situation where all of the thousands of different sensors and technologies are integrated inside that electronic medical records. And so what we need to do is really looking at that holistic person-centered care and these straddle somewhere between the acute facilities, primary care, and social care as well. Lastly, and touch on what we're doing to support caring person at home as well. Knowing that we've gone to also the virtual emergency care service in Queensland, which went live this year, and that's within the healthcare improvement unit portfolio too. That's very much access to emergency department physicians and patients, which are brilliant for those more high acuity patients. They're also very costly. So we don't have at the moment virtual access to GPs easily. So this is a choice architecture project that we're doing at the Rockhampton Emergency Department. Rockhampton is a remote part of Queensland that has a very poorly supported primary healthcare system. A lot of our patients present to the emergency department because they cannot access their GP, or they can't afford their GP. They're in bulk billing or fully funded consultations there. So what we've done as an initiative of last resort is to put a virtual care pod co-located outside the emergency department to support consumers to choose a virtual GP consultation if in fact that's the reason why they're presenting to the emergency department at first place. This little plan is my daughter there in the bottom left-hand corner. It perfect like that TARDIS, that big blue thing on the left. And Enver did a really important design session with her, and she said it looks like a toilet, so it leads to changing outside. So we wrapped it in a local image to help it be grounded in the local Rockhampton community. And she came up with some things we called the virtual care pods. And she said we need colour on the inside because it's too boring. So I commissioned a local Indigenous artist to do some wonderful work from us sitting inside there for the event program for Queensland, which should go live next week. Great. Thank you, Sarantha. Thank you to our panelists for providing that overview. So I'm now going to embark on some questions. We're now going to start with you. It's been an absolute pleasure following the journey of RPA virtual, and I was there working with you where COVID hit, and Teresa Anderson again, feel think only a few weeks to upscale the virtual hospital and shifted from an option to a necessity in delivering care. And now it's evolving into a statewide. And you and I have had discussions that nationally we've seen different strategies and different models in taking the local virtual services, the digital services, and trying to expand it into a statewide service. So can you share some of your insight on the key enablers and or infrastructure that's required to scale from a local level to a statewide service?
Sure. I do have a bit of a list here, but I will keep it brief. Just moving away from technology, from data, I think starting with the basics is really critical. So a documented clinical model of care for whether a clinical condition is being treated is really essential. I'm showing you look ready, Susie, and associated procedures, and that really supports standardization and minimizes risk, which is particularly important when you're rolling out more broadly and in more settings. In addition, business continuity plans are really important for virtual care services, in particular in relation to power and network outages. We really try move ahead with our those. I mean, 2 days of very hot weather happening at the moment. We keep wondering if we're going to have to move to a BCP for a power outage. Really rigorous ICT assessment of security and privacy considerations for any platform we're using, any application we're using, all of our devices before we launch care. A search workforce, particularly volumes unpredictable where the services are expected to grow very quickly, and systems to support clinicians to work remotely. So we're not setting up virtual hospitals to house all of our clinicians. We want our clinicians to have flexibility to be based at home, at another site, in another state, in another country. And we really need this to be able to attract the types of nursing and medical staff that we require. And then those clinicians need to be set up appropriately. So they need remote access to network applications, including our electronic medical record and referral and monitoring platforms. And they need access to a cloud-based telephone system so they have full functionality for wherever they're located. We need a video call system that has capacity for limitless virtual clinics, really, and the concurrent virtual calls. When patients shouldn't have to download any specific apps or software to connect to care, they should be able to do that through a web-based browser. And then finally, because of the statewide nature, we really need an online portal that has information that's kept current, up to date, that's easily searchable as a database by geographic area, all the important visual points.
Great, thank you. Samantha, can I come to you around your experience with the NHS? And we know that they've been leaders in implementing virtual care and the smart hospitals. I think I've read in their long-term plan that by end of this year, they want to treat us at 50,000 patients monthly virtually. What are the learnings from your role within the NHS Trust that we can bring to scaling into statewide services? I think, like all these things, there's a lot of what to do and what not to do, and recognition that the UK is not unique in Australia. We're in kind of a bit of a similar position. What the UK does do, much better than I would say Australia does, is a genuine strategic investment in partnerships between academia and industry to really support the development of evidence-based digital solutions. Like all these things, there's a lot of what to do and what not to do, and recognition that the UK is not unique in Australia. We're in kind of a similar position. At least what the UK does do much better than I'm saying Australia does is a genuine strategic investment in partnerships between academia and industry to really support the development of evidence-based digital solutions. So that is a fundamental change. If we create environments where the solutions are not ultimately fit for purpose, then there is going to be issues with non-adoptions and abandonment of technologies, both from the needs perspective and also the consumers. So there is a heavy amount of work with this team here looking at developing these technologies together to make sure that they are really user-friendly, to more meaningfully support scam spread. So that's a key thing. And there's funding sources in the UK, many more to support research than there are in Australia, unfortunately. But that's where I see an opportunity for Australia to then partner with the UK and academic institutions, because why not? It's technology that can be used there as it can be used here. And we don't need to reinvent the wheel within Australia, nor do we at a global scale. So really trying to leverage all of those different opportunities at home and abroad is, I think, the benefits that we can move in. And that would be a key enabler of change in the UK. Just a food for thought would be, obviously in Australia, utilise UK-based clinicians, in particular looking at imaging departments and doing reporting. Do you see in the future us connecting care globally and receiving care from overseas, from, say, in the UK overnight in Australia?
Yeah, I think you go for it. Yeah. So we have a global workforce.
Yeah.
So we have 360 physicians. We have emergency physicians, pediatric emergency physicians, pediatricians, geriatricians, general practitioners, nurse practitioners specializing in pediatrics, aged care, palliative care, diabetes. The news artists are all over the world, but they have to be Australian per registers. I do believe, and this is where I'm known for being very controversial and thinking very big. I think you have to know the lay of the land. So this is an immigrant. I, in 2013, decided to marry an Australian. And we decided to move across to Sydney. I thought it would be an easy journey. But I love, I'm American. I went to university. People heard I was all be easy. Well, I had to go through the ranks. Right? I had to go eat my curvation. I showed up in the hospital super happy. And then I realized it's not the medicine, it's the culture. This huge learning curve. When I practiced medicine in America, part of my friendship was watching a video of Discover Your House completely. When I practiced medicine in Australia, is used brain. And it completely breaks. So totally different. Something I'm going to say you have to have been registered and trained in Australia to be able to work in this system. So I would love some of this seriously. And I think there's a shift. Or at least probably that's where it needs to be.
No, I agree with you. Yeah, and this is another point, is that being mindful of the fact that there's a global workforce shortage. So drawing on resources from other jurisdictions means that we're potentially depleting those resources there. So if we want to be good global citizens, it's less about taking from abroad to fill our coffers, but more about how we could work collaboratively to invest in change, digitally enabled change. Obviously, that's our conversation point here. That's great. And on to change, because you and I had a big discussion around this, one of my passion areas, around the virtual expansion of virtual care models. And we've talked, whether it's NHS, led by Miranda here in Australia and yourself, and more moving towards that. Yet, and I think the audience here would agree, most of our healthcare budget ends up being built of hospitals, traditional and big gap hospitals. Why do you think we continue to build more hospitals, yet we're focusing on care in the hive?
It's 3-year funding cycles.
Yeah, they should move them kind of.
Well, I love no offense to people in this room who are supported by building hospitals. I'm done with this. I think that we just have to say, and imagine we could take some of that money, put it into virtual. And when I say virtual, it's honestly often hybrid care. Let's be real. Right? It's hybrid care. Putting it into hybrid care, and then you all can go give me a window in the emergency department. If you give me a courtyard, I'll be your big hug. Right. Big pair. So I worked in probably 15 hospitals across the globe, and one is on a window. One. So imagine if you could build the hospital you wanted to, because we have less hospitals, because people are being cared for at home. And then, of course, we need to, it's all about healthcare, not sick care, right? It's just revolutionizing how we think about it in general. And so I think it's a political problem here. It's really sensitive, right? They have it right. We're getting 40 new hospitals. And the politicians are thinking about how to staff it. Rely on the people to staff it on what they're really being used for. So I think it actually to be really fun to be in your seats because we're about to do a really rapid change. And how you can take all the money wasted from not building new hospitals to build great ones that are truly fit for purpose and that will truly create healthcare. But I can try to go with hospital, Courtney Hospital. Maybe if you long build a house for it's a community center. So I can walk in the front door and go swim, go to the basketball, I want you to marry if you have the lights and marry. Like just to make it less about being sick and more about being an everyday experience. Oh, I just happened to go there for a different reason today. I got my pitch going, not all over. Yeah, and it happened.
Love it, Fury. No, you did it. You did it. Miranda, just I wanted to touch on, obviously, RPA is going through a redevelopment. How is virtual care being considered in the design of the new RPA hospital?
So you mentioned our former chief executive previously, yes, Trezes, and she's 30 heritage. She's leading the SDPR in New South Wales. Also at the moment. So the virtual hospital vision was her own, and it came at the time when she was finalising the plans for the RPA hospital redevelopment. And she actually scaled back on the number of beds and the number of emergency bays, with a view to introducing a virtual hospital to take some of the demand out of the physical hospital. So that's sort of how we initiated RPA virtual hospital. Just touching on your point about funding, we've been grappling with this for 5 years now, and activity-based funding doesn't give us the flexibility we need to adequately fund virtual hospitals. It's so unsophisticated, and the classifications we are funded under are just inadequate for any kind of complex acute care. So we're all trying very hard to provide public health with data, evidence, research, evaluation to inform their decision making about the introduction of new virtual care classification systems for activity-based funding. And we're hopeful that we'll see some positive change over the coming years.
And look, I think it's similar within the private. More recently, I spoke at the Health Insurance Summit, and the private providers are really wanting to also come on this journey on provision of virtual and digital care. And again, the funding models are really restricting their innovative, approach to being able to deliver care, which we obviously experience as well on the public side. We've talked a lot around the delivery of virtual care, but what I wanted to touch on what you and I have spoken about before is the digital inequality. And I think our presentation before also mentioned the access to technology as well. So what are the key strategies you're utilising at RPA Hospital to actually overcome these digital barriers?
This should be a really foundational principle of healthcare service, including a virtual healthcare service. We've done a range of things. From the beginning, we made a commitment that any patient who did have a smart device to engage in care would be provided with one. Patients arrived on a smartphone or an iPad with a data package for the period of care, until discharge from us. We also have a partnership with social employers called Work Ventures. They repurpose funds, and for people who are particularly in financial age, we distribute through their smartphone with 6 months of water. You get about time when patients are in the keep device. So that's one way to do that. That's really important. How that is having regular use junior healthcare chaperones, health support workers. You can make sure that the patients are able to actually reach out with what they need. But really important, the information we provide about the virtual care app we will be delivering, how you use the technology needs to be made available in other languages. That's often not done. It's not in 1 or 2 languages because of cost. We're genuine providing information in the given languages. That are individually important. Fragments. We talked briefly about iPads, Robins, adhere with virtual regular rotation. We provide patients with frequent iPads and presenting a screen, and they allow patients to participate in physiotherapy programs from home. On a point, we introduced a position fairly early on when we identified a need. The digital patient navigator, or sort of concierge type position, that helps to assist patients to set up their technology, become familiar with what they're using, and their availability as a
Great, thank you. Susie, what's been your experience starting in a hotel room and now being a expanded virtual statewide service? What are the key barriers that you've identified, and what have been the solutions you've put into place?
solution. So we started at Northern Hospital, which here is emergency department in the state of Etobicoke panel. I think there's 40 different languages that come through regularly. So we have to, from day one, deal with American tourist population for our service. And you come into it on the registration page in foreign languages. Better surface with all call. And also more to a disability agency to highlight and make sure how we integrate make mobile. And then also the benefit of the fact that so many presentations come through healthcare providers. So about 50% of the patients we see are people in Victoria calling us on their own. About calling in the front of the healthcare. Super helpful because we have a health literate internet for a nurse. Where our weakness is elderly that are remote and regional. He do not have a level sound, but to connect with solution very worth it. Because we cannot think people by our own standards just on the phone. It's a first change of interrogation on the phone. Video in the same ballpark. So we do not worry. We truly rely, we will say enough. But works for another.
Perfect. And I think BHI recently released a report, and it showed that audio-only consultations, they reported a less positive experience by consumers as well, and they didn't recommend that. I might also touch on, Samantha, you touched on the pods, and obviously Queensland being quite a large state. Do you want to tell us a little bit more around that project and being a solution to a barrier you've identified for accessing digital care?
Yeah, I'm very happy to. So that's a really interesting initiative. Obviously, the need was driven by, we do a lot of site reviews of different facilities to mitigate unwarranted variation in care right across all the facilities. One of the key issues was this enormous pressure on the emergency department. The main issue that they have is access block, actually. It's getting people out of the acute beds into community homes. But what we have in that region is a pretty population that has poor connectivity, as well as lower levels of digital health that's received for Queensland and national averages. And so, and then poor access to primary care. This initiative is a contentious one, because what we don't want to do is bring primary care patients to the emergency department. That kind of flies in the face of what, the health system's been trying to do for decades. But we do recognise that it was a starting point in the right direction and a safe place to have those early engagements for people that are otherwise very, very digitally excluded. And so it is a model that is supported by a concierge as well, that is someone to just help orient individuals to the environment, to gain connectivity, and then provide some education post-consultation of where they go. The stage beyond this is actually these pods being well out in the community, away from the hospitals, but in the local libraries, in the pharmacies and elsewhere. So I do a lot of work with the State Library of Queensland that has a remit to support digital transformation of all the libraries. And it is amazing how many people access virtual care and video consultations for specialist outpatient consultations in the local library. And so the librarians are now becoming these educators of sorts. So it marrying up with that initiative and hopefully, and evaluating it heavily from a range of different perspectives, is also the development of that role of we don't have a standardized term, but the digital health enablement officer, the digital health navigator, this person who supports consumers. So I pump primed last year an evaluation, a project that funds these roles in various different ways across hospitals and health services to then evaluate their worth, to then justify that workforce expansion. Because if it's not direct clinical care, it often doesn't get funded. And while we can leverage the volunteer workforce, which is great, they're not a guaranteed thing. It is an essential service, and we should approach it as such. So these kind of two things come hand in hand. Now I want to come to a topic area that we've discussed around living labs and test beds. Having collaborated with universities and on health precincts, there's always a discussion where they go, where they should be, how they function. And we know that these environments really allow us to test that real world technology in our services. Can you share how living labs or test beds support digital transformation and the value they bring to our health system? Yeah. So test bed, living labs, these terms are used somewhat interchangeably as well, but they're environments that are purposefully designed to support the testing and trialing of processes of devices, technologies, whatever it may be. I conceive that there are 4 different types of environments that these are. So an in situ living lab is very much a ward, a live clinical setting that also has critical ICT to support its use for research and evaluation purposes. We currently go through the status quo and a lot of facilities of pilot projects of digital technologies that slow down the whole process. And then there's a 17-year gap between when you get the evidence to then translating into practice. This is absurd. So we need to, when we design facilities, not just the clinical care, but design them with the view that we must always collect research and evaluation of the things, the people, the processes, how the built environment and the way that we use those facilities connect with each other. So that's an in situ facility. There's also an on-site simulation facilities that are very much like our education environments. So there were 2 pictures before that I showed. These are kind of bread and butter in healthcare facilities, very much for clinical education. In Queensland, we're very, very privileged to have something called the Clinical Skills Development Service, which is the biggest network of simulated settings in the Southern Hemisphere. So we have over 130 networked simulation sites of various different capabilities and sizes that truly were there to support our clinical workforce with education as it ought to as a base layer. But what we haven't done is leverage those capabilities to support the scaffolding of evidence in a way. So instead of going from a shiny PowerPoint presentation of this new thing that's been developed perhaps without the end user to then a pilot project, we now leveraging those environments to support the meaningful evaluation, testing and trying of technologies, devices, whatever it may be, so that we can kind of move through this whole process faster. There is a concept of the valleys of death in digital transformation. I don't know if anyone knows this here, but it's going through this. We have processes of innovation and these cycles. There are many different points of failure along that journey. And so this is a bridge to leverage the environments that we have. And please do, my ask is really, really build these environments into as a core capability of in all the facilities that you have. So that's use the real world settings to really meaningfully support research and evaluation, but then also these simulated sites too. So the Queensland Innovation Living Lab is very, very new, but it allows us to objectively evaluate the human-computer interaction, the cognitive burden of processes of technologies. And we do recognise that whatever there are flaws in our process of certification in Australia. So the TGA, if you have TGA approval, it doesn't actually mean for some things that you've had an end user involved in the design and development of that thing, which is really problematic. And so what they do call for is post-market surveillance. We don't do post-market surveillance very well in the healthcare system. So going into it eyes wide open and saying this is a limitation in the digital transformation space. So we need to create environments that allow us to test and trial technologies with industry in partnership with academia to move through all these cycles faster.
Thank you, Samantha, Miranda, and Susie. I'm now just going to open the floor to questions.